Hello, good evening. Welcome back to My IVF Answers. We are once again back here today to discuss recurrent pregnancy loss this time. As you know, we were here yesterday. We discussed IVF process with Sofia Meletti, and if you had a chance to listen to her, I'm sure you found it very interesting. But as you know, we are again here today to discuss a totally different topic, and we have a different guest today. As you can see, Dr. Abraham Zavala is with us. Hello, welcome back. It's lovely to have you back. We previously discussed PCOS. That was last year. We mentioned this even before we started this evening. So welcome back, Dr. Zavala. Thank you so much for joining. How are you?
Here again. Yeah.
Good to have you for sure. So as you know, today we will talk about recurrent pregnancy loss, a tough topic. And Dr. Zavala has a presentation, of course, on our topic just to introduce the causes, what can be done in this particular situation. But afterwards, as always, there will be time for your questions. I do see some questions in the chat already, so thanks a lot for those. Remember, this is all anonymous, and we'll be happy to answer as many questions as possible. And the whole event will take approximately 1 hour. So keep the questions coming, and I think that we can go ahead with our presentation. Before we start, just let me mention that Dr. Abraham Zavala, he is the fertility specialist at Clínica Tambre. So welcome back, and I'm really excited to have you back with us for sure. And ready to start the presentation?
Yeah, ready when you are.
Thank you so much, and let's go for it.
Okay, so good evening, everyone. As we've said, I'm Abraham Zavala. I'm one of the gynecologists at Tambre Clinic in Spain. And today we'll be covering a topic called recurrent pregnancy loss, or RPL. And what we're going to try to do today is really understand the causes and explore the solutions that we have with RPL. So what we're going to be covering today is, first of all, the definition of what RPL is, or what recurrent pregnancy loss is. We're going to give a brief overview of all the potential causes that are implied in RPL. And then we're going to do a step-by-step diagnostic workup of what the point of all the tests that we usually consider during RPL, what their purpose is, and how useful they really are to both provide us with information and also to give us valuable information to increase our chances of achieving pregnancy, of course, and the management options in terms of treatment and support for the patients that are undergoing RPL, and then finally give a brief key takeaway before we begin with the questions. So yeah, let's jump right in. So first of all, what is RPL? So RPL, or recurrent pregnancy loss, there are two terms that we have to define in order to understand RPL. So the first term would be pregnancy loss by itself, okay? So pregnancy loss, we will use this term whenever there's a spontaneous end of pregnancy before around week 20. And I say around week 20 because the definition of pregnancy loss varies between each healthcare system in each country. It's usually at the limit of viability, so it can be anywhere from week 20 to week 24. To oversimplify it a bit, let's just say week 20. So it's any pregnancy that is lost before that 20th week mark. The loss can be anything from a miscarriage to a biochemical pregnancy, to an ectopic pregnancy, or even a molar pregnancy. Okay, so it's basically any type of pregnancy loss occurring before week 20. On the other hand, we have a miscarriage. So a miscarriage is going to be a more specific term in which we're going to designate clinically proven pregnancies, usually by a scan inside, seen inside of the uterus, and lost before week 20. Okay, so this term is going to exclude some of the conditions that are kind of grouped under pregnancy loss. So, for example, an ectopic pregnancy, a biochemical pregnancy, and a molar pregnancy would not be specifically considered under the miscarriage term. Okay, and that brings us to recurrent pregnancy loss. Okay, so one of the first differences that we're going to make between this term and the previous ones, and semantics is very important, is that RPL is a condition. Okay, so a pregnancy loss, a miscarriage are, however unfortunate, are actually quite common in the population. Okay, that means that they don't usually need treatment. But RPL is actually a condition. Okay, it's a condition that needs specific clinical support and treatment. Okay, so it's a condition of failure of 2 or more clinically recognized pregnancies. I think a more specific term for this condition would actually be recurrent miscarriage, but the accepted terminology is recurrent pregnancy loss. Okay, so diving in a little bit more on this terminology, ectopic and molar pregnancies are not included within the RPL definition. Biochemical losses is going to depend. Some societies do include it, some don't. And then there's finally a distinction between between primary RPL and secondary RPL. Primary RPL is going to be an RPL that has no previous successful pregnancies, while secondary RPL is an RPL that happens after the woman has had a successful pregnancy. Okay, so what causes RPL? So while there are certain risk factors that we've identified, the more common risk factors are age, over 38, an increased BMI, usually above 30, and a previous pregnancy loss. Okay, those are the more important risk factors that can actually be associated to RPL. However, it's important to mention that up to 50% of the time, we are not going to have any identifiable risk factor. Okay, this is something very important to keep in mind. Now, how common is it? Okay, so as I said before, pregnancy loss or miscarriage are pretty common in the population, in the sense that up to a third of pregnancies will end up as a miscarriage. Okay, but that usually tends to be something spontaneous that happens, that doesn't repeat itself. However, having recurrent pregnancy losses, which is defined by having 2 or more pregnancy failures, is rather rare if you compare it to the general population. But if you think of 1 to 4% of all women, well, that increases the amount of patients that undergo this condition. However, the silver lining here is that up to 2/3 of women that experience RPL within 5 years will achieve pregnancy. Okay. Now, one of the challenges that we have in doing research for RPL is really defining this condition. Okay, so for that we use first of all gestational age. When we talk about RPL, we usually mean the first 12 weeks of pregnancy. That's the time period in which most pregnancy losses occur. Okay, we're talking about pregnancies between week 12 to 20 only have about a 1% chance of suffering a miscarriage. So it's really that previous conception to 12 weeks, which is the time period that really encompasses most miscarriages. We also make a distinction between a biochemical, an embryonic, or a fetal miscarriage, in the sense that biochemical is something that is going to increase our HCG level. So we're going to have a positive pregnancy test, but those hormonal levels are going to decrease. We're not going to get a scan of the pregnancy. Okay. Embryonic and fetal, we are going to see it with an ultrasound scan. And of course, previous episodes of pregnancy loss are very important, because that's how we're actually going to define RPL. Okay, so there are two broad causes that, as fertility specialists, we can look into to identify a possible cause of recurrent pregnancy loss. Okay, now by far the most important risk factor and cause is maternal age. And the reason why maternal age is related to recurrent pregnancy loss is because there's an increase in chromosomal errors that can happen when generating the embryo. Okay. Now, there are, of course, other genetic factors that are not age-related that can also increase the rate of miscarriage, and we'll look into those. And then we have another category that doesn't have anything to do with the egg cell, the sperm cell, or the embryo as the previous category, which is the uterus and the autoimmune environment. So these are not related to maternal age, but these can include structural uterine abnormalities, which we'll go into, autoimmune disorders, blood clot disorders, which are called thrombophilias, and certain endocrine factors. Okay, so the first thing that we need to address is how maternal age, how it impacts the miscarriage rate. Okay, so we have this graph in which we see a kind of J-shaped incidence of miscarriages. As you can see, if you look towards the left of the x-axis, okay, we'll find women between the age of 20 to 23, and how the miscarriage rate, or the proportion of miscarriage rate, is a little bit higher than the age group from 25 to 29. And that's why we call it a kind of J-shaped graph. And that's because women between 25 to 29 have the lowest risk of miscarriage. And as you can tell, it increases with age after 30 years of age, but around 50% of miscarriages are concentrated in the age population over 42. Now, the reason why age can generate abnormal embryos is through two genetic pathways. And the more common one is the chromosomes, when they're rearranging themselves, they can fail to separate. And that way they can either carry over a chromosome or not be able to carry two chromosomes. And you end up having less chromosome in the following cell. And also balanced translocations. So as chromosomes are dividing, they can separate and rearrange in ways that is not compatible with a healthy embryo development. Okay, and there are two moments in which that will happen. So we have two cell division processes. One is going to be called meiosis, and that's going to be taking a parent cell with 46 chromosomes and dividing in a way that each of the daughter cells each have 23 chromosomes. So there's going to be a reduction in the chromosome content. And this is where that failure to separate, or the actual term is non-disjunction. This is where most chromosome abnormalities arise. And the second process in cell division is mitosis. And this would be the way in which, for example, the embryo cells multiply. This is going to generate copies of the same cell. And those are what we would call structural abnormalities. But then there are abnormalities that can happen within the chromosomes itself. And here we have three examples of a type of translocations that can happen between the chromosomes. And as I've said, that's when certain parts of the chromosomes, when rearranging, will rearrange in a manner that is not compatible with a healthy embryo development. And even includes what we call inversions, which are segments of the chromosomes that'll be in a way inverted over their poles, and will give us an abnormal chromosome content. Then there are also alterations which can happen within the sperm cells. Okay, and one of these is what we call fragmentation. Okay, so the chromosomes that are within the sperm cell's head are stored in the shape of DNA threads. Okay, the way that these DNA threads are packed, if they're packed too tightly, these DNA threads can sometimes break, or better yet, the correct term would be they can fragment. Okay, now most males will have a certain degree of fragmentation. I've personally never seen a fragmentation test result of 0. Okay, there's always some fragmentation. There are two types of fragmentation. There are single strand fragmentation and double strand fragmentation. Now, the single strand fragmentation is usually going to be able to be repaired by the egg cell. And this is, of course, going to depend on the egg's quality. So an egg cell with less quality is not going to be able to repair the fragmentation as efficiently. So this is a point in which both the amount of fragmentation and the egg's ability to repair that fragmentation really come into place. And then there's another type of double strand of fragmentation, which is the double strand fragmentation. Now, this fragmentation is usually repaired through lab techniques. So that's part of the importance in being able to see these abnormalities in the sperm sample before doing the fertilization process. And then there are epigenetic modifications that can happen to the sperm DNA, but these are usually determined through the male's lifestyle factors. Smoking, sun exposure, a sedentary lifestyle, sitting, physical activity, all these types of lifestyle factors that can impact the sperm's quality, and sperm aneuploidies. So these are basically going to be sperm cells that have an abnormal number of chromosomes. Okay. And I just want to make it clear that we've talked about the genetic aspect of RPL, and because these are the ones that are going to affect either the egg cells through maternal age and quality, the sperm cells through aneuploidies, fragmentation, and epigenetic changes, and the embryo's genetic content, which is basically going to be embryos that either have or don't have a normal number of chromosomes. Okay, and now we're going to talk about the uterus and the environment. Okay, so one of the things that we study is the anatomical structure of the uterus. There are anatomical abnormalities that are more prevalent or more frequent in patients with RPL. That means that certain anatomical abnormalities will be easier to find in patients that are going through some type of infertility or specifically RPL. Okay, and the difference, one of the ways that we can kind of suspect an anatomical abnormality is that these pregnancy losses tend to be later in the first trimester. Okay, that's one of the ways that we could suspect this. And in this image, I have three of the main uterine abnormalities. We have a unicornate uterus, and then we have what we call a D-Delphi uterus. But the one labeled D, which is a septate uterus, is one of the structural abnormalities that are more related to RPL and that actually have treatment. So it's always important to keep in mind this type of anatomical abnormality. Okay, and so anatomical abnormalities women are born with. Okay, but there are also abnormalities that are acquired or that happen later in life. Okay, and one of these abnormalities is a fibroid. So a fibroid or fibroids are benign tumors that come from a disorganized growth of muscle cells. As we have to remember that the uterine is a type of muscle, smooth muscle, but muscle nonetheless. And fibroids are one of the more common benign tumors that women can have. And they're, depending on the location of these fibroids, is going to depend the impact that it can have on pregnancy loss. Okay, we have fibroids that are inside the cavity, which we call submucosal fibroids. Then we have fibroids that are within the wall, which we call intramural fibroids. And lastly, we have fibroids that are completely outside of the uterus, which we call subserous. Okay, now the only fibroids that we can relate to pregnancy loss are those that happen within the cavity itself. So in the image that is labeled as E, I don't know if you're able to see it, but there's the one that's more on the left. That's an example of a fibroid or a myoma that happens inside the cavity and hence is more related to pregnancy loss. There are also polyps that have a similar impact on pregnancy loss. And finally, adhesions. So adhesions are connections between the walls of the uterus that can happen as a type of scar tissue. When we have a lot of them, we usually call this Asherman syndrome. And it can interfere both with menstruation, but also with fertility and with RPL. And one of the factors that would make us suspect that there might be adhesions would be a patient that has probably gone through several D&C procedures. That's usually the scenario in which we see the adhesions. Okay, then there's something bit more subtle, which is chronic endometritis. Okay, now whenever we see that itis suffix in medical terms, it usually means inflammation. Okay, and that's precisely what chronic endometritis is a localized inflammation of the endometrium, or what we call the uterine lining. Okay, and this is usually caused by infections, usually bacterial infections, but there seems to be some research going into viral infections that may also cause chronic endometritis. It's not the infection itself, but the impact that it has on the lining. And this is an inflammatory impact on that lining, which interferes with a normal pregnancy development. And one of the challenges with chronic endometritis is that it tends to be asymptomatic. That means that it doesn't cause any symptoms, or very subtle symptoms that we're not able to suspect come from the lining. So this is another factor that we usually look into when we have RPL. Okay, then we have the uterine immune system. So pregnancy, like many other conditions, are very tightly regulated by the immune system. Okay, we have to remember that the embryo is at least 50% a foreign entity to your body. And in cases such as egg donation, for example, this can be up to 100% a foreign entity. So it's important to remember that it's going to be regulated by the immune system, whether or not it can attach or not to the uterus. And there are several key players that regulate this immune response. One of them is the NK cells. So the NK cells, or natural killer cells, are a type of white cell that are more prevalent in the second phase of the cycle, when that embryo is trying to attach to the lining. Then there is the KIR HLA system, and the KIR is the receptor that your uterine cells are going to express, and the HLA system is what the embryo is going to express. And we know that there are certain combinations that are more favorable for implantation than others. And finally, anti-thyroid antibodies. So we're not sure how much anti-thyroid antibodies, how much they can impact RPL or not, but we think that it can affect thyroid function, and that can definitely affect RPL. Okay, so this is an image in which in the top half we have a normal lining and an embryo attaching into that lining. And one of the more important images that we can see here is how, if you look at the top right side, okay, that is how the embryo is attaching to the lining and making its way through the maternal blood vessels to get that communication between the embryo and the maternal body. Okay, and in the bottom half, we have examples in which, for example, in the lower left corner, we have a endometrium that is infiltrated by what we call plasma cells, which are cells that would be prevalent in the case of chronic endometritis. And these can affect the immune response and also the endometrium's development. Okay, and there's the topic of thrombophilias. Okay, so thrombophilias is a condition in which the body is more prone to making blood clots. Okay, there are certain lifestyle factors, and normal points in your life in which you might be more prone to making a blood clot. One of the more common examples is pregnancy itself. However, there are certain genetic mutations that might make you already more prone to making blood clots, and we call these inherited thrombophilias. Okay, and then there are acquired thrombophilias. These conditions are not acquired through genetic mutations, but you do develop them during your lifetime. And we've seen very weak correlations between inherited thrombophilias and recurrent pregnancy loss, but we've seen a clear relation between acquired thrombophilias, such as antiphospholipid syndrome and RPL. So that's one of the conditions that when we have RPL, we do need to study because it is treatable. Okay, and finally, we have endocrine factors that might affect RPL. So we know that thyroid function is not just very important for a normal pregnancy development, since it has such a huge impact on the embryo's neural development, but it can also be related to pregnancy loss and recurrent pregnancy loss. And that's where we think that the thyroid antibodies might have an impact. We know that just having elevated antithyroid antibodies or treating antithyroid antibodies doesn't have much of an impact in treating RPL. However, overt hypothyroidism should be treated. Then we have PCOS, polycystic ovarian syndrome. There is a relation between PCOS and RPL. We don't know if it's because of the PCOS itself or if it's related to the insulin resistance, diabetes, and obesity that usually comes with PCOS or that can be found in PCOS. For example, obesity after maternal age is one of the factors that is most closely related to pregnancy loss. And we've found that women with PCOS and an BMI of over 30 have the same rates of pregnancy loss as women without PCOS, but with a BMI over 30. So we know there's a relation between PCOS and RPL, but we don't exactly know what that relation is or to what extent. Vitamin D is one of the vitamins that is present in many processes in the body, and the embryo's implantation isn't not one of them. So it's always important to also treat vitamin D deficiency when we see it. We know that just taking vitamin D in the absence of a deficiency doesn't really give us any benefit. But if we do have that deficiency, it's always important to adequately supplement it. Okay, and you might be wondering, how do we study all of this? Okay, so this slide is really more for patients to understand how we can find all of this information out. So, for example, through a blood test, we could find the karyotype. That means the chromosomes that each parent has. Okay, we can do the thrombophilia panel for inherited thrombophilias. We would find out those mutations that way. We could also see the KIR HLA profiles that the parents can have. And we can also test for vitamin D levels. Okay, so that can all be explored through a blood test. The sperm analysis, or through the sperm analysis, we can do a FISH study to determine whether there's an abnormal number of chromosomes in the sperm cells. And we can also find the DNA fragmentation rate. Okay, that's made through the sperm sample. Okay. Then the PGTA is a study that we perform on the embryo's cells and with which we can determine if that embryo has the correct number of chromosomes, doesn't have the correct number of chromosomes, or is sort of something in between called a mosaic embryo. Okay. Then through the hysteroscopy or 3D scan, we can see the uterine cavity's size. We can see whether there are any anatomical abnormalities, and whether there are any polyps or fibroids that we may not have seen in a standard 2D ultrasound scan. And finally, the endometrial biopsy is going to tell us what the microbiome is like. So that means what the good bacteria profile is, whether there are any plasma cells or bad bacteria present that could be causing chronic endometritis. And we can also see the NK cell profile. Now, you can also test the NK cells through a blood test. And that's certainly the way that we used to do it. But now we look more at the uterine NK cells to get that information. Okay, so those are a lot of tests. Okay, unfortunately, they don't all have the robust evidence that we need in order to recommend it, right? I think that there are certain situations in which you want to explore those possibilities. And certainly each patient has a very particular situation. But this is a brief summary of what tests we can do that have that robust evidence to back them up, basically. So for example, if we start at the top left, whenever we have a clinically recognized miscarriage, again, that's a miscarriage that we've been able to get the evidence from an ultrasound scan. With one miscarriage, we really don't need to do much in terms of studies or treatment. We know that that's something that may happen, okay? If there's first trimester bleeding with a history of one previous miscarriage, this is something that we would call threatened miscarriage, and we know that that recommending vaginal progesterone does help with that situation. Now, when we have more than 2 miscarriages, that's when we recommend testing for certain risk factors. Of course, risk factors like age, obesity, and lifestyle factors is something that we can just find out during an interview. But other risk factors such as antiphospholipid syndrome, hypothyroidism, uterine abnormalities, are all things that we would need to do additional testing for. Okay, and the way that we can treat both of these categories are, for example, fragmentation within the sperm's DNA. We can treat it through certain sperm selection techniques and also through good quality egg cells. Chromosomal abnormalities or the suspicion of chromosomal abnormalities, we could treat through PGTA, which is a whole topic on its own. But just to kind of summarize the actions that we can take, we can just say PGTA. And then for the uterine and autoimmune recurrent failures, for uterine abnormalities or fibroids or polyps, we can look at surgical management. In the case of chronic endometritis or an abnormal microbiome, we can use antibiotics and probiotic therapies to improve our endometrial receptivity. We can use certain immune therapies in cases such as an abnormal NK cell number or an incompatible HLA and KIR system. anticoagulant therapy through heparin and or low molecular weight heparin and low-dose aspirin in conditions such as acquired thrombophilias, such as antiphospholipid syndrome, and hormonal and vitamin D supplementation if needed. Okay, and one of the last aspects that I want to talk about is psychological support, because this is something that unfortunately sometimes goes underexplored during the consultation. We need to understand that RPL is something that profoundly affects the quality of life of both women and men or their partners. And it affects them in different ways. And we know that RPL is a very frustrating condition that unfortunately also puts the relationship at risk. So this is something that should not go unnoticed and that should be properly addressed. Okay, things like an increase in anxiety or depression following both RPL and RPL diagnosis are important. They are less pronounced in women that already have successful pregnancies, but can affect the quality of life nonetheless. And it even can go as far as women that would rather not conceive rather than risk another miscarriage. And there is some evidence that psychological support can have a beneficial impact on pregnancy outcome. So it's definitely something that should not go unnoticed. Okay, and the take-home message or the key takeaways would be that RPL is a prevalent and distressing disorder. Okay, it's a psychological and physical burden on both women and their partners. Unfortunately, outcomes haven't really improved much since the late 90s, in spite of having much more information, especially much more information in terms of genetics and immunology. And new approaches for both for prediction, prevention, and management are warranted. But for that, we need to really make a more stringent clinical definition of what RPL is. And this needs to lead to more research and more trials of homogeneous populations of RPL. So thank you so much for your attention. Now, if you have any questions, I'd be happy to take them.
Brilliant. Thank you so much. As always, it was a great presentation. You've explained all those details and walked us through all the aspects of RPL. So thanks a lot for that. And we now go for your questions. So there are some questions in the chat for us. And now, as I mentioned, there will be time for your questions. There are plenty of those already here. Some of them are quite long, but let me just show those questions, and I just need to put them in one so it's easier. And let me show you this. You can see that there is some history that what has been done so far. Mm-hmm. After all these tests, we consulted with doctor at the University of Zurich. He told us that no specific issues were identified and advised to continue trying to conceive naturally. There's no information about the age, I'm afraid, here. I don't see it. Additionally, he recommended PGTA, PGTM. The question is, we really want to have a child, do not want to leave anything to chance. What would you recommend? And there is, there is the information.
That's it. So it says that that he is 41 years old. I'm guessing. Please correct me if I'm wrong. And
wife is 38.
Wife is 38, and you have been married for 9 years. The first 4 years of marriages, my wife underwent treatment for vaginismus. Later, she had surgery for a fibroid in the uterine wall, which was approximately 7 centimeters in size. The submucosal fibroid was shaved, but it could not be completely removed. It was just something that can happen. Yeah. Currently, a part of the fibroid, or 1 to 2 centimeters, remains in the uterine wall. After the surgery, she became pregnant 3 times, but unfortunately had miscarriages each time. At the University Hospital Zurich, we underwent thorough examination in the endocrinology and andrology departments, including, and that was part 2.
This one. Yeah, sorry, it was the other way around.
No problem. Okay, so first of all, we have we first of all have a case of secondary infertility, because you've had, if I remember correctly from the first from the first message, some miscarriages, right?
Yeah,
Three
sorry,
times
I
we're really
cannot
happy miscarriages.
display it for
Yeah.
a reason.
So
I
this is what
see
we
it.
would specifically consider RPL. Okay, and one of the main causes of RPL is maternal age, due to its impact on its chromosome anomalies. Okay, so while trying to conceive naturally is an option, I think that IVF would be a way in which you would consider performing a PGTA. The PGTM, from what you describe right now, doesn't seem like it would be necessary, because the PGTM is oriented to specific genetic mutations within the embryo that are not related to RPL. However, the PGTA would help us identify one of the main causes of RPL, which is an embryo's aneuploidy. So in this case, I do think that IVF with PGTA would be a option that you can consider.
Okay. Thank you so much for your questions, of course. I do hope that was helpful. If there's anything else you wish to add, you still have time. Go ahead, type this in, okay? But I do believe it was helpful. And let's have a look. There are more questions. Nicole would like to know, so is there any scientific proof adding microchips to stranded and double sperm that improves sperm quality, or is this method more of a marketing tool with unproven results? Anything you can
Okay,
advise?
so let me just provide the rest of the listeners with some context. So we talked about DNA fragmentation, and we talked about how there were single strand DNA fragmentation and double strand DNA fragmentation. While the single strand DNA fragmentation is usually corrected by the egg cell, the double strand fragmentation usually needs lab techniques to correct. Okay, one of the ways that you can correct these double strand fragmentations is to what is marketed as the fertile chip or fertile chip. Another technique is, for example, the sperm selection technique. So it helps reduce fragmentation, and we know that double strand fragmentation and single strand fragmentation do have an impact on the blastocyst rate, the implantation rate, and the miscarriage rate. So it is something that we should treat if we see it. Depending on the amount of double strand fragmentation rate, the chip might be the better option, or other sperm selection techniques. So that's going to depend on two things: the type of test through which you tested for the DNA fragmentation, and the amount of DNA fragmentation.
Okay, brilliant. Thank you. Nicole actually has one more question, so I will just go straight to that one. My uterus is slightly inverted. Doctors have to use extra catheter to transfer embryos. Procedure is usually painful for me and rigorous for the doctor. Could this extra manipulation harm the embryos? I have 7 failures using egg donation with no underlying causes. I had every test possible at Tambre and now my new clinic, and I am trying to find failure factors. Anything?
Well, this is certainly hits close to home, right? Having by inverted, I don't know if you mean retroverted, which is when the uterus is kind of pointing backwards, or if you mean rotated. However, that should not have any impact on the embryos. It might have an impact on how difficult the transfer is. And for that, I think that doing a mock transfer test, that is testing different catheters before the embryo transfer, might be something that is useful to whoever performs the embryo transfer. That way, at the moment, they can have readily available the best catheter for you.
Sure. All right. Thank you so much. That's again helpful, I believe. And let me just have a look. More questions are here, and Connor would like to know, would you have any comment on the reference of oxidative stress and also homocysteine to RPL?
Yeah. Oxidative stress can affect or can have an effect on both egg cells, and which is actually one of the mechanisms by which ovarian aging occurs. And it can also have a negative effect on sperm cells. So potent antioxidants can benefit both women and men due to its impact on oxidative stress. And what was the second part of the question?
Sure. Of course, let me just go right here. Yeah.
And also homocysteine to RPL. Yeah, so homocysteine or an increase of homocysteine is something that we can see in, especially in when there's an enzyme called the MTFHR mutation. And at that point, it is something that we want to treat with more easily to metabolize types of folic acid. That usually will help us bring down the homocysteine levels. And we know that while the MTFHR mutation can increase our homocysteine levels, the relation that it can have to RPL is not very well evidenced.
Okay, again, thank you. Next question from Peter. Duration from sperm sample to ICSI. Can you give target duration, impact to example fragmentation if this takes too long?
Can you rephrase the question? So, because I don't really understand it. Can you give target?
I wasn't sure myself, but just wanted to check maybe.
Peter, can you please rephrase the question? I'd be happy to answer.
Definitely, we will be happy to go back. So let us know, and let me go to the next question. Okay, and Peter also added here that we had fibroids removed, 19.
Wow. Yeah.
By surgery. How many months after can IVB be retried, if at all?
Okay, so that's going to depend on where these fibroids were. Okay, and one of the limits that we use as gynecologists, surgeons, is whether, first of all, whether the surgery was through hysteroscopy or through laparoscopy or through laparotomy, and how deep did we go into the uterus for the removal of the fibroids. And that's going to determine the amount of time that we need to wait before we can try for pregnancy. So I would ask your gynecologist to look over the surgery report and determine how long you need to wait before the next surgery.
Yeah, makes sense. Again, thank you. Of course, let me go to next question from Nadine. Any correlation between adenomyosis and RPL? I had 2 biochemicals using donor X. What testing would you advise before any further transfers?
Sure, but just to add one more comment to Peter's last question. For example, it's kind of the same logic that we use in C-sections. For example, when we perform a C-section, since we open the uterus, we wait from anywhere to 12 to more like 18 months before the next surgery. So depending on how much they cut into the uterine wall, that's going to determine the time before the next pregnancy. Okay, sorry about that. I just wanted to.
It's okay, of course. That's why we are here to explain. Let me just go back then to this. So this is the question. So what is the correlation between an adenomyosis and RPL, two biochemicals using donor X? What testing would you advise before any further tests?
Okay, so adenomyosis, again, for the rest of the listeners, is a condition in which the endometrial lining, which is inside the cavity of the uterus, infiltrates into the uterine wall. So this is actually a type of endometriosis, what we call a deep infiltrating lesion. Okay, and the way that adenomyosis can affect the fertility outcome is, we think, because it affects the way that the uterine wall contracts. It may cause it to either contract more than it should, or not as much as it should. So I would certainly address that through what we call a down regulation protocol. That means giving you certain hormones a few months before the embryo transfer to see if that decreases the amount of adenomyosis before the transfer.
Okay, next question here. I will go back to the previous questions, but I have adenomyosis, but also the uterus is having a lot of water. How can it be helped? I had 3 IVF failures.
Okay, so when you say water, I'd be interested in knowing where the water is. My instinct would be to think that you mean adenomyomas, which can be seen sometimes in the scan as sort of fluid collections within the wall of the uterus. That's one of the things that I think that you mentioned. But another thing that we can sometimes see is a type of fluid within the endometrial cavity. Now, these two are very different from one another. So if you could specify a little more, that'd be great. If not, I'm thinking that you refer to a type of adenomyosis, and it's very similar to my last response. Trying a downregulation protocol before the next transfer to see if that decreases the amount of adenomyosis.
Okay, thank you so much. That's why I wanted to put those two together. But of course, if there's anything else, know what to do. Okay, let us know. Let me just check. Okay, Peter has added some more information. So, okay, just a second. I just need to publish that. So this is in regards to our previous one, right? So as to the time, between sperm sample and ICSI, some studies point to DNA fragmentation increases with time. The sperm wait until ICSI, and longer delay might be significant for RPL. Some say 1 hour, others say 4.5.
Okay. So to be honest, I'm not sure whether there is a difference in fragmentation between the sample and ICSI, but we know there is a decrease in fragmentation with a shorter abstinence period. So abstinence periods of 2 to 3 days as opposed to 5 to 6 days might yield a sample with less fragmentation. So that could be something to consider.
Okay, hope that helped. Thanks a lot for sending the message once again. Now it was definitely clear. Okay, let me show you the next question. So I had a fresh embryo transfer with donor eggs 3 months ago. The embryo didn't implant. I have been experiencing lac spotting 3-5 days prior to my menstrual cycle since the fresh transfer. Could this issue have an impact on the outcome of future embryo transfer? If it's ongoing, I had a hysteroscopy a few months before the embryo transfer, so no issues were detected.
Let me see. The embryo didn't implant. I have been experiencing light spotting prior to my menstrual cycle since the fresh transfer. Okay, but I'm guessing that you've already had a negative pregnancy test from the transfer, and in your subsequent cycles, you're getting some spotting before your period. That depends, and I think that in order to answer this, we would need to take a look at your hormonal levels and the medication that you're on. That would probably give us a better picture of what may be going on. However, even if it is something like that, if the hysteroscopy found no issue, which would be one of our main concerns, because a fibroid or a polyp could be causing that. Don't worry, because the medication that you're going to be on for the preparation cycle should not cause any bleeding.
Okay, thank you. Let us know if that answers your question, of course, and thanks a lot. And let me just go to the next one. Sorry, I have more information again here, so it will be a longer question. Just give me a second. I'm trying to display it. It's right here. Okay. I'm 34. My husband also. We lost 2 pregnancies. I have MTHFR mutation, TAY, right? You can see the details, but no other serious mutations. I do have here HLA C1, C2. My husband has C2, C2. We also did karyotype testing and everything is okay. Tested hormonally, everything was okay. Husband's sperm tested as well. All good. I do have AC, anti-chlamydia, trachomatis. You can see the details. Could this be the cause? PCR tests are negative, and what would you recommend to do?
Okay, so let's kind of break this down by the factors that we talked about during our presentation. So you're 34, okay? So at this age, we can see a decrease in the egg quality, but that should not be the main quality. Can you leave the question up just so I can
Sure,
go
yeah,
through?
definitely.
So then you have an MTHFR mutation, which is something that we've already talked about. As long as your homocysteine levels are fine and you're taking folic acid, this should not be an issue. The PAI 4G 5G mutation, particularly the 4G 5G, could affect your clotting factors. So while there's not much evidence for that, I think that during the transfer, I would use at least low-dose heparin to see if that increases our chances at all. Now, the KIR-BX and your HLA-C1, C2, and your husband being C2, C2, we know that a BX KIR profile may benefit from a C2, C2 HLA phenotype in the embryo, which most embryos, as it is, should have that profile, should have that C2 profile. So, I don't think that there's much to do in that sense. Normal karyotypes, tested hormonally, and everything was fine. Sperm tested, it was all good. Doesn't seem like there's an active infection. So that doesn't seem to be the cause. So I think that in this case, unless you've already tried it, I think that's something that you need to consider is a PGTA, just to make sure that the embryo that you are transferring is chromosomically normal, and that's not the cause.
Mm-hmm. Okay, again, lots of details. Thank you so much. I do hope it was useful. And now let's go to our next question. My partner has 51% sperm DNA fragmentation. What sperm selection would you recommend? In this case, we are using donor egg due to recurrent miscarriage issue with miscarriages.
Okay, so I take it that the miscarriages were from before you moved into egg donation. So the fragmentation rate, to even know whether that's increased or not, we would need to know what test that was done with. And we would need to know whether that's single strand fragmentation or double strand fragmentation. So I don't think that we have enough information to be able to answer this.
Okay, sure. Thank you. Let me go to the next. Well, there's actually a follow-up because, of course, this is the patient that we discussed before, and I'm trying to show you that previous question just so we can make sure. This is the new question here. So let me just show you. So what if I chose to do a natural frozen embryo transfer instead of medicated one? Would the spotting not have an impact on that transfer? This is regarding the spotting, right?
Yeah, and that's the thing. You know, I've had a few patients that have that we've tried to do a modified natural cycle, and they kept having that spotting. And the thing is, that can affect us in two ways. On one hand, it might affect the endometrial thickness. And on the other hand, we really don't want blood at the time of the embryo transfer. So if you are having spotting with a natural cycle, I would advise that you go on a substitute cycle or a hormonal cycle, to make sure that there isn't any spotting, and thus making sure that there isn't any blood present at the time of the embryo transfer.
All right. Again, thanks a lot for this. There are like 2 questions left, I believe, and we will be slowly finishing. So this will be the final call for the questions, okay? And let's have a look. Again, Nicole already asked questions before. I tend to experience intermittent uterine contractions, which most commonly cause contractions, and can you suggest preventive or reduction measures?
Well, it's going to depend on when you're having those contractions. There are certain hormonal tests that we can perform during the preparation cycle that might let us suspect whether there's going to be an increase of contractility. So we usually do this through testing for estrogen levels. And there are certain medications that we can use during the embryo transfer that can help us have less contractility in the uterus.
Okay, thank you. And possibly our final question for today. So let me just show you once again here. I started with my own eggs, but it was unsuccessful, age 46. I'm now moving to donor egg. What is the best technique? IVF ICSI. Sperm quality is good as sperm, yeah, donor sperm will be used.
Well, you can really go with either conventional IVF or ICSI. What I would do is I would talk to one of the embryologists at the clinic that you're being treated at, and see what they recommend specifically. You know, some clinics are more comfortable with one type of fertilization than the other, but by using egg donor and sperm donor, you can really opt for either conventional IVF or sperm injection.
Okay, I do believe it was clear. Someone is typing, so I just want to make sure that we've answered all of your questions. It looks like it, but if there's another question, I just want to see it. But it looks like that was just like that was another. Thank you for answering the question. And
I see one that says, "What test can reveal fibroids in the uterine cavity?" But I don't know.
Let me see. Okay, yeah, sure. Sorry, this will be the Nicole question, which I think I missed. Yeah, what tests can reveal fibroids in the uterine cavity?
So we can see a lot of fibroids through the conventional 2D ultrasound scan. We can also have a better look inside the cavity with a 3D ultrasound scan. But we're going to be more interested in the fibroids that are within the cavity, and for that, the best test would be a hysteroscopy. There's also the HSG test, but I really think that the hysteroscopy is a more suitable test for looking at the fibroids within the cavity, and also offers the chance of treating it if you find them.
Okay. Again, thank you so much for yet another question and answer. It looks like that was definitely our final question. So thanks a lot, everyone, for your time. Useful session, lots of different questions as always. So thanks a lot. I do hope it was useful. We are also here to support you. So thank you so much, Dr. Zavala. Thank you so much for joining. Any final words before we finish for today?
No, it's great to be back, and hope to be back soon. So thank you so much for the opportunity. And
thank you.
Thank you everyone for your questions.
Definitely. And just to let you know, after we finish, you will be redirected to our survey. So I can only encourage you to take part in it and let us know what you think about this and all our previous webinars. As you know, there are more events coming up. I'm sure we will speak with Dr. Zavala quite soon as well. There are plenty of topics to discuss. So I'm really looking forward to it already. And I just also want to invite you. We will be back tomorrow. And actually, Dr. Janessa will be actually joining us tomorrow as well from Clinica Tambre. We will have another Ask Your Doctor event with 3 fertility specialists from three different clinics. So I hope you will be able to join us. We will be live tomorrow at 7 p.m. London time. So don't hesitate. So you can go to my IVF website, my IVF Answers website, where you will find all of our upcoming events. Thanks a lot for today. Thank you, Dr. Zavala. See you quite soon. Have a lovely evening. Take care.